Good day, all our Egyptian Society of Cardiology members and followers from Egypt and all over the world. My name is Mohamed Zahran. I'm currently the president of the Continuous Medical Education Working Group of the Egyptian Society of Cardiology, and I'm working currently as an associate professor of cardiology at Ain Shams University. I will take the next 30 minutes to discuss with you the revascularization guidelines in the chronic coronary syndromes or the stable coronary artery disease. Where are the European Society of Cardiology guidelines staying with us now? So this is the latest version. This is the 2018 version of the European Society of Cardiology in collaboration with the European Association of Cardiothoracic Surgeons for the guidelines on the myocardial revascularization. And there were some upgrades and downgrades in the acute coronary syndrome as well as the stable coronary artery disease or the chronic coronary syndrome, which is the new term used now, from which we are focusing that for the PCI of the bifurcation lesions, the stent implantation is usually performed in the main vessel only, known as the provisional stenting. And this can be followed by a pot, of course, and after that you will assess the side branch if you need to stent the side branch or not. So this is regarding the stable coronary artery disease involving a bifurcation lesion, and this was an upgrade to class 1 recommendation, of course. And regarding the intracoronary imaging for stent implantation, the OCT also was upgraded from a class 2B to a class 2A. So first of all, let's agree that revascularizing a patient is a multidisciplinary decision-making approach, and it does not involve only the cardiologist and the patient. It can involve the cardiac surgeon, can involve the anesthesiologist, and it also can involve the other specialties if needed according to the comorbidities of the patient. There is a specific recommendations regarding the consent to perform such a procedure, and there are some guidelines regarding the timing of the revascularization. So of course, if you have a stable coronary artery disease, that you will not do an ad hoc PCI, meaning that you will not re-intervene upon in the same setting according to the heart team protocol of your hospital because it's not an emergency situation. So of course, you need to discuss with the heart team the multidisciplinary decision making, and of course, the written consent of your patient should be signed and informed. The time to the revascularization is usually within the first 2 weeks if the patient is representing by a high-risk profile, and within 6 weeks for all the other PCI patients. And this allows enough time for the diagnostic procedure to be assessed properly by the whole team. But of course, if you are going to perform an ad hoc procedure, then you have your heart team ad hoc. You will review the films of the coronary angiography, and you will decide that this patient is a little bit higher risk and will need to perform the procedure ad hoc. Of course, you need a written informed consent as well. So the question that always rises in the field of chronic coronary syndrome or stable coronary artery disease: what is the rationale for revascularization? Why am I performing this revascularization procedure? So we always agree upon that the best piece of nut or the best piece of sweets in our practice is saving lives. So revascularization can be actually directed towards saving lives, and we know that this is the case scenario in case of acute coronary syndromes, in cases of STEMIs, in cases of very large burden of ischemia proven by non-invasive or invasive techniques. But also, the question is always attacking the chronic coronary syndrome, the revascularization procedure, and the trials keep going. Lately, we have the results from the ischemia trial also, and we have the meta-analysis for all the trials starting in the 1990s comparing PCI to CABG and revascularization versus medical therapy. And actually, what we need to know regarding the stable coronary artery disease is that in most of the cases, it is a symptomatic relief from the symptoms of myocardial ischemia, and in some cases it involves improving the prognosis of the patient. And of course, improving the prognosis of the patient will depend upon the level of the myocardium that is subtended or subjected to ischemia. So whether you are going to perform a conservative therapy in the form of medical treatment only and optimize medical therapy, or whether you're going to perform a PCI procedure to relieve the symptoms and improve the quality of life, which by the way is a very important and a very noble goal as well. And if you are going to perform a CABG procedure to this patient, so this is a tailored approach on patient per patient basis, and this involves the discussion with the all heart team members and including the patient also to individualize the decision according to this patient after fully explaining the risks and benefit of whatever procedure that you choose. Regarding the revascularization choice of between the PCI and the CABG, just take care there are specific points to be considered that were highlighted by the guidelines. Those include the technical feasibility or the anatomical complexity of the vessels of those patients, represented by the syntax score. Number two, is the patient diabetic or not, because adding diabetes as a risk factor per se moves us towards a better decision towards revascularizing the patient surgically by CABG. And number three is the ejection fraction of the patient, and which is surprisingly, but yet it goes very logic, that the lower the ejection fraction of the patient, the more will be the benefit that is suspected from performing a high risk procedure, even if the risk is high, but the benefit will be also big in the term of mortality benefit. So what are the indications for the revascularization in patients with chronic stable angina or stable coronary artery disease or chronic coronary syndrome, whatever term you prefer to use, even if those patient has a silent ischemia? So you need to know, as we said, that there are indications for the prognosis of the patient and there are indications for the symptom relief and lifestyle, of course, improvement. So if you have a left main disease with a critical stenosis more than 50%, or you have a proximal LAD stenosis that is more than 50%, or if you have a 2 or 3 vessel disease with stenosis more than 50% and an impaired LV function with an LV ejection fraction below than or equal to 35%, or a large area of ischemia detected by functional testing that represent more than 10% of the left ventricular mass or volume of myocardium, or abnormal invasive FFR, or if this is the single remaining patent coronary artery disease. As you know and as you see, the green light is everywhere. This is a class 1 level of recommendation to perform the revascularization procedure, and we did not here say which revascularization procedure we're going to use, whether it is through intervention or via surgery. For symptomatic control, other than those 5 indications that we said, usually the revascularization procedure, of course, would be directed towards a hemodynamically significant coronary stenosis in the presence of limiting angina that is not controlled properly by the medical therapy. So in this case, you will go towards the intervention or towards the revascularization by surgery, but you need to explain to the patient that this is for symptomatic control, for better quality of life. It does not involve a real prognostic benefit, but of course the quality of life and the symptomatic control are also very important for the patient. There is no reason or there is no rationale for having the patient having a limiting angina that is not controlled on medical therapy, and you keep making him suffering more and more, because this can be solved only simply by a stent or a graft. I would like here to focus upon the role of FFR, which it would be significant if the FFR is below 0.8, or if the IFR is below than 0.9, actually 0.89 to be equal or less than, or of course visually a 90% stenosis, not only 50 or 70% stenosis visually on the coronary angiography. And of course, if the FFR is even below the 0.75, this is usually a prognostically relevant lesion for this patient. So now we have known the indications for the revascularization, whether it is for symptomatic control or whether it is actually showing the patient a prognostic benefit. And we showed the 5 indications for the prognostic benefit and the hemodynamically significant lesion for the symptomatic control. and we're gonna discuss with the patient. We agreed that this patient will do a revascularization procedure. So the next question that will jump to our mind is, what is the mode of revascularization? Are you going to intervene upon this vessel, or you're going to perform a cabbage procedure? So as we said here, we need to put three factors into this equation. Number one is the coronary artery disease complexity, and here we are using the anatomical syntax score to calculate the anatomical complexity of the coronary artery disease. Putting into consideration when studying the anatomy of a specific patient that you need to perform a complete revascularization, and we are advocated against performing partial revascularization when the other technique will offer us the option of complete revascularization. The second point that will actually be put in the equation also is if the patient is diabetic or not, and the LV ejection fraction. So let's see these specific scenarios here mentioned by the guidelines. So in a stable coronary artery disease where the coronary anatomy is suitable to perform any one of those procedures, I mean he is amenable for PCI, and he has a low predicted surgical risk of mortality, so he is also a candidate for cabbage, and he presents with a one vessel coronary artery disease, let's say a mid-segment focal right coronary artery stenosis or an obtuse marginal or LCX stenosis. So it's a one vessel disease that is not involving a proximal LAD. PCI of course is class 1, cabbage is class 2B, because it looks a little bit illogic for the cabbage procedure that will not be involving lima or an internal memory artery graft to the LAD. So usually if you have a circumflex or an RCA, you will not refer this patient for a cabbage procedure. Of course, if it involves a proximal LAD stenosis, then the cabbage will be a class 1. Of course, PCI is also a class 1. For two-vessel coronary artery disease, if they have a proximal LAD stenosis, both of them are class 1. If does not involve, then cabbage would be a class 2B. Okay, so here we come to the specific subset of the left main coronary artery disease. As we know that the syntax tertiles are 3, you have the low syntax score, or the first tertile, which is 0 to 22, and then you have the intermediate syntax score 23 to 32, and the higher one, which is 33 or more. So actually in the low syntax score, and this patient we are not speaking about, we're speaking about left main disease only, not multivessel or something. So left main disease with a low syntax score, both PCI and cabbage have a class 1 level of A recommendation for an amenable for PCI or low surgical mortality for cabbage. If it is in the intermediate risk score, cabbage also stays as class 1, PCI falls a little bit to class 2A. But let's speak about the third tertile, by which is the syntax score is 33 points or more, and this means that we have a complex anatomy, and most probably we cannot achieve a total complete revascularization using the PCI procedure. So in this case, the PCI is a class 3. You should not do. Cabbage stays as class 1 level of evidence A. And here this is a simple comparison for the multi-vessel disease with and without diabetes. And let me start speaking those with diabetes on the right hand side of your screen. If you have a 3-vessel disease with low syntax score and diabetes, it's 2B class of recommendation for the PCI. And if you are in the intermediate or the high syntax score, let me say that PCI is a class 3. It is not recommended to do a PCI if the patient is diabetic, while of course in all the tertiles, cabbage is a class 1 level of evidence A for diabetics. But if the situation is a little bit different and you take diabetes outside from this equation, so the 3-vessel disease with a low syntax score of 0 to 22, class 1 level of evidence A for PCI as well as for cabbage, and as the more complex vessels arise in the intermediate and the high syntax score, the anatomy becomes complex, the distalities become more affected, the restenosis with the drug-eluting stents is also there, and most of the times you cannot achieve a complete or total revascularization. So in this case, the PCI is a class of recommendation 3, which means that you should not perform the PCI, and of course cabbage remains as 1A. So we have some clinical and anatomical characteristics beyond the little bit of the guidelines that mentioned that would direct us towards favoring one of the two options. Let's say that you have a very old patient that is frail actually, and you cannot achieve the total revascularization procedure, and he cannot go through the anesthesia and the post-operative care because he has a COPD in advanced case, presence of severe comorbidities. So these clinical characteristics, of course, would favor the PCI procedure. And of course, as the anatomy we said previously, the syntax score, the intermediate and the high, and the severe chest deformities, chest radiation, and porcelain aorta, because those would be against performing the cabbage procedure. On the other hand, you have several clinical and anatomical characteristics that would favor a cabbage. If there is diabetes, as we said, if the LV ejection fraction is below 35, as we said, if there is a contraindication to using any of the dual antiplatelet therapy, and if you get a recurrent diffuse in-stent restenosis. Of course, anatomically and technically, the high syntax score beyond 23, the second and the third tertile, incomplete revascularization by PCI, severely calcified vessels that would not allow you to properly insert and inflate your devices successfully. And of course, if he has another indication for surgery, for example, an aortic aneurysm or something, are going to intervene upon in a heart valve as well. So revascularization in diabetics, to sum up, it's the same as non-diabetics, putting into consideration that there is a specific factor in diabetes that favors the cabbage, and as we said previously, go back to the syntax score and identify your tertile of options. So in the revascularization of the patients with impaired LV ejection fraction, it is a class 1 recommendation to perform, of course, in those patients, the revascularization procedure. And as you see in the second point, that the cabbage or the surgery is the first revascularization choice, so long as they have an accepted surgical risks. As we can show here, that in the patients with the 1 or 2 vessel disease, the PCI should be considered as an alternative to cabbage if you can perform a total or complete revascularization and the vessels have a syntax score that would help you to perform this revascularization completely. But if you have a 3 vessel disease, take care that this is a heart team evaluation, of course, and most probably it will move towards surgery. If you're going to perform a surgery and you have an LV aneurysm actually that will impair the LV ejection fraction in the future, and the LV aneurysmectomy would have been a very good option for this particular subset of patients, especially those with the advanced NIHA class of heart failure 3 and 4, if they have a large thrombus formation or the aneurysm is causing for the patient arrhythmias. Of course, surgical ventricular restoration during the cabbage may be considered in specific patients in specific centers with specific expertise. So, do we have specific recommendations about the point of the contrast-induced nephropathy? Of course, it is recommended to check the renal function if the patients are taking metformin immediately before the angiography, and you can withhold the metformin if the renal function is deteriorated. Take care that sometimes the patient's also performing a multi-slice CT, and is recommended also for the multi-slice CT to follow the same recommendations. Of course, adequate hydration is number one. The use of the low osmolar or iso-osmolar contrast is recommended, and the amount of the contrast volume divided by the GFR should be less than 3.7. Take care that the high dose of statins, rosuvastatin 40 or 20 milligrams or atorvastatin 80 milligrams is also a class 2A recommendation, and pre or post hydration with isotonic, not hypotonic saline should be done, and also following up the urine output. It's usually 1 milligram per kilogram per hour in the 12 hours before, to be continued for 24 hours after. If your patient has a risk of pulmonary congestion due to impaired LV ejection fraction or high NIHA class, you can reduce to half the dose. Of course, hemodialysis is not recommended as a preventive measure, but actually prophylactic hemofiltration can be done 6 hours before the complex PCI procedure with a fluid replacement of 1000 milliliter per hour, of course, without the negative loss, and this saline hydration to be continued for 24 hours after the procedure. Specific points to be considered in the post-CABG patients. Those with early post-operative ischemia and graft failure, you need not to hesitate. This is managed as an acute coronary syndrome. You would go with the ECG, the biomarkers. You will search for new segmental wall motion abnormalities, hemodynamic or electric instability, and if there is an emergency, you will go with a coronary angiography. If you have something amenable for PCI, you will manage as an acute coronary syndrome. Otherwise, you will reoperate surgically after the discussion with the heart team. Regarding the late graft failure, especially with the venous grafts and the disease progression, of course, this may mandate a repeated revascularization according to the, as we agreed previously, the large areas of ischemia or the severe symptomatic that is not controlled by medical therapy. And in this case, the PCI as a redo procedure would be much more feasible and accessible than the CABG as a redo surgery. Some procedural aspects: if you're going to perform a CABG, the CABG wins because of the internal mammary artery. So the internal mammary artery is the conduit of choice, of course, especially for a redo CABG where the internal mammary artery was not used previously. And the redo CABG, of course, will involve a lima or an internal mammary artery with a graft to the LAD. Sometimes, as we know, that we have an option between the radial arterial graft or the saphenous vein graft. The radial artery graft is recommended over the saphenous vein graft. And of course, the bilateral internal mammary artery using as arterial graft, yes, would be highly recommended for those actually with a low risk of sternal wound infection, because usually the patient needs the REMA for healing of the sternum, especially if he is diabetic with uncontrolled A1C. Regarding the vessel harvesting, the skeletonized internal mammary artery dissection is recommended. Do not leave the vessel actually attached to the intercostals, and the steel phenomena would happen. So you can actually perform a very good harvesting. Endoscopic vein harvesting for the saphenous vein graft with the no-touch technique also should be considered if you are going to perform an open end harvesting for the vein. Off-pump CABG as a minimally invasive procedure involving a no-touch technique for the vein is also recommended, as you see, especially for those patients with significant atherosclerosis in the aorta with a higher risk of post-operative strokes also, but it needs a specific team, of course, specific learning curve, specific surgeon in a specific hospital. And there is still some role for a hybrid procedure where you can perform a lima to the LAD and then you can perform the stent to the circumflex or the OM in specific centers involving both teams actively. Patients with recurrent episodes of diffuse in-stent restenosis, the patient's response to the stent, especially the drug-eluting stents, has already been seen to fail in specific patients, so CABG is an option. Or if you're going to perform something in an in-stent restenosis, the intracoronary imaging will help you so much regarding the stent choice of the size, of course, the apposition, the post-dilatation, the atherosclerosis extent, and so on. If you're going to perform a PCI On a vein graft, distal protection, because there's high risk of embolization, is recommended. And if you're gonna perform a PCI in a post-CABG patient, revascularize the native vessels would be a much better option than revascularizing the vein grafts of the surgery, because the rate of degeneration is high. Restenosis of the PCI, of course, drug-eluting stents are recommended for the treatment of restenosis, and there's specific indication for drug-coated balloon also that can be used, especially in the small vessels. Regarding some arrhythmia, especially atrial fibrillation in the setting of the myocardial revascularization, take care that the perioperative role of oral beta blockers actually can reduce the incidence of post-operative AF after CABG. If AF happens, restore the sinus rhythm. Antiarrhythmic drugs infusion like amiodarone or electrical cardioversion, especially if the patient has a hemodynamic instability. Sometimes the perioperative amiodarone should be considered as a prophylactic therapy to prevent AF after CABG. And this will ask the next question about the anticoagulation. So the long term would be assessed according to the bleeding risk, especially if the patient got a post-operative stroke. Of course, the rate control and anticoagulation are considered as the initial management in asymptomatic post-operative AF rather than drug control by antiarrhythmic drug after you attempt to restore the sinus rhythm. If the patient is already presenting with an atrial fibrillation and he's undergoing a CABG, so the surgical occlusion or exclusion of the left atrial appendage can be considered also for stroke prevention, and this is a class 2B recommendations. Take care according to the choice of the stent and the access site as specific recommendations. So the drug-eluting stents, of course, are recommended over bare metal stents in any PCI regarding the clinical presentation, the lesion type, the planned non-cardiac surgery, the anticipated duration of the depth, or the use of anticoagulant therapy. It's class 1 level of evidence A. Usually it's very, very, very extremely rare to insert a bare metal stent in the year 2020. Radial access is recommended, of course, over the standard approach, unless you expect something like a CTO, you need a dual injections, you need an 8 French guiding catheter, you're going to use an IVUS or rotablation device and so on, then you will go with femoral access also. The bioresorbable scaffolds are no longer recommended because they are in the field of clinical research only. So regarding the intravascular imaging for the procedural optimization, here there was an upgrade for the IVUS or the OCT that should be used in selected patients, especially those involving left main procedure, restenosis. You need to study the angles. You need an IVUS to perform the puncture site in a bifurcating CTO or in an ostial CTO. And the IVUS would help you also to optimize the treatment of unprotected left main lesions. And stent implantation in bifurcations, main vessel, single stent strategy, post dilatation with a pot, and then assess your side branch. If it is fine, TIMI3 flow, there is no atheroma extending in the first 5 millimeters, the vessel size is below 2.5 millimeters, it's not supplying a very big area of the myocardium, it's just pinched, no problem, go with one stent. Otherwise, you decided from the start, this is a big vessel, 3 millimeter size, the ostium is involved, it's not just a carina shift, there's an atherosclerosis, and you cannot recross after you put the main vessel stent. So here you need to rewire the both vessels. You need to adequately choose a 2-stent strategy, but putting into consideration that it's always better with 1 stent for the restenosis and for the future outcomes. The percutaneous revascularization of the CTOs should be considered in the patients with angina that's resistant to medical therapy or with a large area of documented ischemia in the territory of the occluded vessels. We are not plastic surgeons that are going to make the vessels look fine. We don't need to open a CTO in a scarred RCA territory that's less than 2 millimeter size and use equipments for thousands of dollars and pounds. No, we do revascularization, as we said, either to improve the morbidity or improve the mortality of the patients. And we need to ask ourselves before performing any revascularization procedure, what is the magnitude of the expected benefit for this particular patient. And there is a little bit of recommendation because of the DK-CRUSH 5 trial that was published in 2017. In true bifurcations, lesions involving the left main, the DK-CRUSH technique, which was performed as a DK-CRUSH 5 trial for the left main disease, which have been proven in this particular single trial to be preferred over the provisional T stenting. Yes, you can perform the DK, but take care. Lengthy procedure, it needs very good training, and do not start a DK-CRUSH for your practice in a left main disease. Start it first in branches other than left main. After you totally master the procedure, you can go, if you decide, with a 2-stent technique. And thank you so much.